Good morning, and thank you for the invitation and for the introduction. First of all, before we get into the different sodium channel subunit genes, I think I would set the scene and sort of make a review of what is currently known to be associated with this Dravet syndrome or Dravet syndrome-like. That's how we call it normally. That's how we say when it's not fully a Dravet syndrome. I have nothing to declare, and I have to say that the vast majority of patients with Dravet syndrome do carry abnormalities in SCN1A. They are the classical patients with classical phenotype. Yet we've all seen patients who, based on the clinical manifestation, can be classified as resembling Dravet syndrome or this mimicking Dravet syndrome, and they do not carry SCN1A anomalies and abnormalities. So what do they have? What happens when there are no detectable abnormality in SCN1A? If you go into PubMed and you make and you search for DS or DS-like phenotype and genes and genetics, you come up with a list of genes that I've reported in this slide. So we have additional alpha subunit of the sodium channel genes like SCN2A, 8A, 9A, and also SCN1B. We find prothocalorine 19, some of the GABA subunits, STXBP1, potassium channel HCN1, CHD2, and also KCNA2. These are some of the genes listed for this phenotype. But for most of these DS-like phenotypes or DS-like epileptic encephalopathies, the resemblance is limited really only to the occurrence of some seizures during febrile illnesses. So I wanted to discuss with you whether that is appropriate. Should we really say that these patients have a Dravet syndrome phenotype? We'll come to this discussion at the end. So the classification might not be appropriate and might be limiting our understanding of the etiology of these diseases and their therapeutic aspects. So I will. So this presentation will examine the current understanding of the role of non-sodium channel genes in DS, or not SCN1A anyway, and what it is known about the phenotypic similarities and differences. I will not really go into the SCN2A and SCN8A phenotypes, since there are devoted sessions for these genes that are quite relevant in the epileptic encephalopathies field. And will be later on in the morning. I just wanted to mention that mutations in SCN1B, so the beta-1 subunit of the sodium channel, were identified in a patient. It's a homozygous mutation, and the patient had been described as having Dravet syndrome, and that was reported some years ago. And then together with Ingrid, we put together our patients with Dravet syndrome or a DS-like phenotype, and we could not really identify mutations in this gene, and so we could not confirm the finding that mutations in SCN1B actually are underlying Dravet syndrome phenotypes. But let's move into this very interesting story of PCDH19. We all know the story, and we've seen patients with it, with mutations in this gene, and this is really interesting. It was published from the clinical point of view in 1971, when it was described these families with only females affected with epilepsy and mental retardation, and the disease seemed actually to be transmitted by unaffected fathers and unaffected males. And then more than 50 years down the track, Joseph Getz and again Ingrid and all the Australian colleagues published this interesting paper in Nature Genetics discovering the gene associated with this phenotype, which is the PCDH19. And as you can see from the phenotype, from the genealogical trees of these in these families, there are only females affected, and the males are actually transmitting the disorder, which is rather unusual considering that PCDH19 is actually located on chromosome X. So The peculiarity was the transmission, and these patients had focal as well as generalized epilepsies beginning in the first year of life, and there was this atypical X-linked inheritance. A year later, the French group, including RIMA, searched for mutations in PCDH19 in patients resembling Dravet syndrome, so with seizures again occurring during fever, but negative to SCN1A, and they actually identified mutations in some of these patients, and published this interesting paper saying that in these patients, in these female patients, the phenotype resembled Dravet syndrome, and they had PCDH19 mutations. But I guess let me point out some of the, there are overlapping features, probably the seizure of onset, maybe the febrile illnesses again, facilitating the occurrence of seizures, and the regression following seizure onset. But there are also some clinical features that are actually really typical of PCDH19, which I think stands out like a unique disorder, and probably should not be really regarded as ADS-like phenotype. So the seizures tend to occur in clusters, beginning around 10 months, so a little bit later than Dravet syndrome, and they can also present after the 1 year of age, which is really unusual for Dravet syndrome, or almost impossible. There is a milder outcome. Seizures tend to become less frequent over time, and the cognitive impairment is also milder. And about 50% of these female patients actually have autistic features, which we know it's really not that common in Dravet syndrome. And I think we heard it yesterday from Rima saying that autistic features are actually not typical for Dravet syndrome. We contributed to the delineation of this phenotype by having this PCDH19 day in Florence, and where we reviewed all the videos, the ictal seizures of these patients, to really define the semiology of the seizures, and we actually came up with this observation that there is a pattern which is quite frequent, and is represented by the occurrence of focal seizures with vocalization, screaming, and fearful expression, followed by a motor or hypomotor semiology. In our group of patients, the cognitive impairment was actually only present in 70% of the patients. So the important information was that 30% of these female patients actually did not have any kind of mental retardation, which is important. And autistic features are were quite frequent. And these patients have this stormy onset, really have clusters of seizures during febrile illnesses every few months, and tend to go on the seizures for a few days. This is the EEG actually of a patient from here, from Verona, from Bernardo La Bernardina, was included in our paper, and you can see there is this nice focal discharge on the right hemisphere while the patient was having the seizure. The seizure actually arose from sleep. This is the video of one of our patients, one of the patients we reviewed, and as you can see, the patient is actually asleep, and all of a sudden she has this very, she's screaming and fearful with this tonic posture, and I'm sure you can see the face, it's really like a fearful expression, and the tonic posturing. And the patient was actually screaming, and it went on for about a minute or so. She was having several of these seizures during febrile illnesses, most of them arising from sleep. So at present, there are more than 200 mutations reported in this gene, and we know that PCDH19 is the most frequently mutated gene in epilepsy, following SCN1A, and studies of large cohort of female patients showed that mutations in this gene range from 2 to 20%. And the more patients we study, the more things we find. So now we know there are also a few male actually affected with mosaic mutations, and there are also patients with focal with malformations of cortical development, cortical dysplasia with PCDH19. So Moving to the next gene that has been associated with DS-like phenotype, I came across to this CHD2, which was actually published within the Euro-Epinomic Consortium. We performed exome sequencing to patients in a cohort of patients negative to SCN1A, and we identified 3 mutations out of 9 patients with, in this gene, and this gene is an interesting one, so we don't know exactly what the role and the function is, but it seems to be involved in the embryonic development. And these patients were thought to have a DS-like phenotype, but I mean, I don't want to go through all the clinical features, but the most important one, I guess, is the fact that the seizure onset was at 14 months, 2 years, and 3 years and 6 months, which I think is rather late for a Dravet syndrome. And also the phenotype probably was not that really, was resembling perhaps, but not so similar. These are the other patients that were published with mutations in the same gene, and again, the resemblance with Dravet syndrome is it's rather uncertain. There is only one patient with febrile generalized clonic status epilepticus at onset, and with onset within the first year of life, that might have resembled Dravet syndrome amongst all these other patients published. So. Let me now tell you the clinical case. A clinical case. This is a patient we see regularly in Florence. He's now 20, but we've seen him since he was very little. He was born with normal delivery, no problems. He went to have a developmental delay. Independent walking was at nearly 2 years, and he never talked, and he doesn't talk even now. There's no speech. He started having seizures at the age of 5 months with this right hemiclonic prolonged seizure, but it was afebrile. Then 20 days later, he went on and had a second similar hemiclonic seizure. And then later on, from the age of 5 months to 18 months, he developed several of these hemiclonic seizures, all afebrile. And he also had a focal seizure with vomiting at the end. He tried different medications, and when we actually switched him from valproic acid into carbamazepine, he went into a prolonged status epilepticus that needed to be admitted in the ICU, and he was and he developed this right transient hemiparesis. So from then on, he also started to have this eyelid myoclonia, or absences with prominent eyelid myoclonia and photosensitivity. So then we kept seeing him, and we recorded many of these eyelid myoclonias and the photosensitivity. He has a moderate developmental delay, currently absent speech, he's hyperactive and occasionally rather aggressive. His MRIs were normal, and the EEG, as I said, it showed some photosensitivity. I'll show you some of the EEG features. These are some of the spike and wave activities with eyelid myoclonia during photic stimulation at 2 Hertz, and then again at 25 and again at 30. So, does he have a Dravet syndrome? I don't know. We can discuss it. Certainly the exome sequencing didn't come up with any SCN1A mutation, but it showed that the patient had a GABA-A alpha-1 subunit mutation, a de novo mutation, which we thought it was pathogenetic and so actually causative of his phenotype. Together with Catherine Johansen and Rikke Molled and other authors that are also here, we collected a number of patients with mutations in this gene and defined this spectrum of phenotypes. It certainly includes this patient as well as others with epileptic encephalopathies that might resemble Dravet syndrome. But for instance, this patient, yes, it did have hemiclonic seizures, but they were all afebrile. So I don't know if the phenotype could be called DS-like. And the other patients included in these phenotypes and the spectrum can be severe as well as mild, including the genetic generalized epilepsies for mutations in this gene. These are some of other patients published again by Gemma Carville, and they also have this so-called DS-like phenotype with seizures occurring during febrile illnesses. Let me tell you again the story of another patient. This is Emma. Emma developed a seizure at the age of 5 months. The first one was like a classical febrile seizures. And from 9 months following this first febrile seizure, she developed focal, hypomotor, and tonic-clonic seizures, frequently occurring during febrile seizures. She is currently with multifocal seizures increasing during febrile illnesses, so definitely there is an increase of seizure frequency with fever. EEG shows multifocal paroxysmal activity. The brain MRI is normal. She was trialed on several medications, and none of them really worked. A neuropsychological evaluation showed that she had a mild delay from onset, probably even prior to seizure onset, and she's currently on a moderate developmental delay. Mostly is the cognitive function. There are moderately delayed because she can actually walk, and the motor functions are better developed. So Emma, this is the EEG. We recorded several focal seizures when she was admitted because of these febrile illnesses. So is she a Dravet syndrome? Could we classify it so? She actually presented the exome sequencing showed an HCN1A mutation. So this interesting gene that it's a potassium channel gene with this mutation that was a de novo and was thought to be a causative of the phenotype. We know that from Christelle Depien's group that there are patients with mutations in HCN1 causing early infantile epileptic encephalopathy with some features resembling Dravet syndrome, and here are the clinical features, predominantly again these febrile and afebrile seizures are, and again we can discuss if this is a Dravet syndrome or not, or it resembles Dravet syndrome. So then briefly, there are other genes, as I said, associated with Dravet syndrome, like this KCN82, where there is one patient with febrile and afebrile seizures reported in this single paper. There is this recent paper reporting patients with mutations in the beta-3 subunit of the GABA-A receptor, and again, they're said to resemble Dravet syndrome. And then there is this paper published some years ago claiming that mutations in STXBP1 cause Dravet syndrome. So I like this to conclude with this slide. This is a nice summary of the genetic landscape of Dravet syndrome and of epileptic encephalopathies mimicking Dravet syndrome, which was published in 2017 by Dr. Steele and the group of Samir Zubairi. It really summarizes that we have a core phenotype of classical Dravet syndrome, and I think the majority of these patients, actually the classical one, have SCN1A mutations. And then around it, there are epileptic encephalopathies mimicking Dravet syndrome with mutations in other genes. And we can probably divide these genes in 3 subgroups: genes coding for voltage-gated ion channels, like the sodium subunits, like the alpha 1, alpha 2, alpha 8, alpha 9, and the beta 1, and then the potassium channels. And then there are genes coding for the ligand-gated chloride channels, like the GABA subunits. And then there are actually genes coding for proteins acting in a different way, like the PCDH19, CHD2, and the STXBP1. And I'm sure there are many more genes to be added to this slide and to be included. So some reflections, is this distinction between the true and classical Dravet syndrome and the mimicking Dravet syndrome really necessary and relevant? Could it be regarded as a semantic one? Or it is, or it will become important to inform our diagnostic and therapeutic approach, as precision medicine might need a precise and fast recognition of the epilepsy type and of its etiology to move forward. Thank you for your attention.